Good morning, everyone. My name is Ashley O'Donnell, and I am a clinical quality consultant with the Iowa Healthcare Collaborative. Today, we're going to talk about pressure ulcer prevention in the hospital setting. So I wanted to give you a little background on who I am and where I come from. The Iowa Healthcare Collaborative Hospital Improvement Innovation Network works closely with multiple hospitals in the state of Iowa, South Dakota, and Illinois on improving patient safety and quality. Our overarching goal is to reduce all-cause harm by 20% in all of our participating hospitals. One of these areas that we look at closely is hospital-acquired pressure ulcers. So here are our objectives for the day. We're going to be able to understand the key elements of a comprehensive skin assessment, describe the purpose of the Braden scale, understand how to tailor pressure ulcer prevention interventions to each patient individually, and review pressure ulcer staging and understand the difference between the stages. So what's the big deal? Why are we so concerned about pressure ulcers? Although pressure ulcers are preventable in most every case, the prevalence of pressure ulcers in healthcare facilities continues to rise. 2.5 million patients per year are affected by pressure ulcers, and about 60,000 patients die as a direct result of those pressure ulcers each year. Not only are these patients getting sick and dying from these pressure ulcers, but the pressure ulcers are costing $9.1 to $11.6 billion per year in the United States. Individual patient care can range from $20,000 to $151,000 per pressure ulcer. Not only do we care about these statistics, but we also care about our patients, and we want to give them the best care they can. So what does evidence-based practice tell us? We need to complete a comprehensive skin assessment on admission and at least once a day on all patients. We also need to complete a risk assessment, which is typically the Braden scale, on admission and per your facility's protocol, whether this is once a shift, once a day, or more. Once these two steps are completed, a care plan needs to be identified. The care plan looks at what prevention strategies and interventions are appropriate for this patient. Each care plan needs to be tailored specifically to the patient that you're working with. We also need to document all findings appropriately in the electronic health record. If we do not document that a patient came into the hospital with a pressure ulcer, the hospital will be responsible for that pressure ulcer. It is also important to put all this information into the electronic health record for communication purposes. Everyone involved in the patient's care needs to know if a patient currently has a pressure ulcer or if they are high risk for developing a pressure ulcer. Not only should we be communicating this in the medical record, but we should be communicating this during shift change report, multidisciplinary rounds, and also to the patient and the family. They need to be included in their care and understand what they're at risk for, and if they already have a pressure ulcer, how we're working to take care of this. So this is a pressure ulcer prevention clinical pathway tool I wanted to share. It is a little hard to see, but it's a great resource, so I still wanted to share it with you. If you look at the top part of the screen, you'll see that the top square says patient is admitted or readmitted. You need to be doing both. You need to be doing the left side and the right side. So starting with the head to toe skin assessment. This goes over all the stages of a skin assessment, which we'll go over a little bit later. But pretty much what it's telling you is that if the patient has no skin issues, you can start with the pressure ulcer risk assessment and move on. If they do, you need to report any abnormal findings to the healthcare provider and notify any patient and family on your findings. You need to continue to keep a close eye on them, and you need to do the risk assessment score to be able to identify interventions that need to be done. If the patient has a current or healed pressure ulcer, you need to document this very thoroughly in the patient's chart. You need to be able to document the location, the length, the width, the depth, the stage. And you need to speak to the physician about what the next step will be. Once you're done with the head-to-toe skin assessment, you need to move on to the pressure ulcer risk assessment. If the patient is at risk, you need to be able to identify a care plan for actual or a potential skin problem. And then these next steps go through the Braden scale and what interventions you could do for each of these, which we will also go over a little bit later. So we'll start with the comprehensive skin assessment. The comprehensive skin assessment is an examination of the entire skin. This needs to be completed on admission and at least once a day. This shouldn't be something that takes extra time. This should be incorporated into your head-to-toe assessment, but it does need to be thorough, and you need to look at every aspect of their skin. So what's the purpose of the comprehensive skin assessment? The purpose is to identify any pressure injuries that may be present. You also need to identify if they've had any pressure injuries in the past, and if they have, where were they located, and was there a certain reason these were caused. You need to be able to determine whether there are any other lesions and skin-related factors that predispose the patient to pressure injury development, such as excessively dry skin, moisture-associated skin damage. You need to identify any other important skin conditions that the patient may have. You also need to use this to incorporate it into your Braden scale, and this will also help you identify care planning needs for that patient. So the elements of a comprehensive skin assessment are to look at the skin temperature, the skin color, the moisture, the turgor, and the skin integrity. So starting with the skin temperature. Increased skin temperature can be a sign of fever, or it could also be a sign of impending skin problems, such as a stage 1 pressure ulcer. So consider using the back of your hand rather than the palm of your hand to assess the temperature of a patient's skin. Compare symmetrical body parts. For example, compare one arm next to the other arm. See if one arm is warmer than the other. You need to look at the skin color. Know what the person's normal skin tone is so that you can evaluate any change. Don't be afraid to ask the patient or the family if this color looks normal compared to their baseline. Look for differences in color between comparable body parts again. So the left leg compared to the right arm compared to the left arm. Look for redness, darker skin tone. Depress any discolored areas to see if they're blanchable or non-blanchable. The non-blanchable skin can be a sign of a stage 1 pressure ulcer as well. Look for paleness, flushing, cyanosis. And remember that changes in coloration may be particularly difficult to see in darkly pigmented skin. You need to look at the skin moisture. Touch the skin to see if the skin is wet or dry or has the right balance of moisture. Remember that dry skin may also appear scaly or lighter in color. Check if it's oily. Note that macerated skin from too much moisture may also appear lighter or feel soft or boggy. And determine if there's any areas that are clammy. Are these changes localized or are they generalized? Does the patient have the clammy areas all over their body, or is it just on one arm or one leg? You also need to assess the skin turgor. To assess skin turgor, take your fingers and pinch the skin near the clavicle or the forearm so that the skin lifts up from the underlying structure. Then let the skin go. If it quickly returns to place, this is normal skin turgor finding. If it does not return to place but does stay up, it's called tenting, and it could be a sign of an abnormal skin turgor finding. Sometimes this is related to dehydration, an older adult, edema, or if they have any connective tissue disease. You need to look at the skin integrity. Look to see if the skin is intact without any cracks or openings. Determine whether the skin is thick or thin. Determine whether any lesions that are currently there are raised or flat. Look for any bruises, any disruptions in the skin, and if there are any disruptions in the skin injury will need to be identified. For example, is it a skin tear? Is it a pressure ulcer that's already been identified? Is it a moisture-associated skin damage? And make sure to chart all these in the electronic health record. Some special tips and tricks while you're doing this comprehensive skin assessment. Make sure to check the skin beneath or around any devices or compression stockings. So for example, any EKG pads, EEG pads, tube feedings, oxygen tubes. Check the bony prominences, the heels, the sacrum, the back of the head, any skin-to-skin areas. This can be a big area where moisture can be trapped and can cause sores. So this could be the back of the knees, the inner thighs, the buttocks, and all areas where the patient may lack sensation to feel pain. Or of course, if they've had a breakdown previously, they're at high risk for developing another breakdown in that same area. All right, so the next thing we're going to talk about is the risk assessment. After you've completed a comprehensive skin assessment, the next step is to turn that information into a risk assessment. So this includes the use of a standardized scale and an assessment of other factors that may increase risk of pressure ulcer development. This is typically used the Braden score. So for example, you may come up with a score But you also need to use your critical thinking skills. Identify if they've had any prior pressure ulcers, if they're a smoker, if they're a palliative care patient. You need to be able to use your thinking skills to add to the total score. So the Braden scale is made up of 6 subscales: sensory perception, moisture, activity, mobility, nutrition, and friction and shear. The lower the Braden score means the higher risk for pressure ulcer development. Typically, a score of 18 or less indicates an at-risk status. So once you come up with your Braden score, you need to identify interventions based on that patient. Tailor interventions based on patient-specific areas of risk. And also, again, you need to communicate the tailored pressure ulcer prevention plan to all staff who interact with that patient, and also share it with the patient and family so they feel involved in their care. Here are some examples of care planning, breaking the information down by each subcategory of the Braden score. We'll go through some example interventions. The purpose of this is to show you that each category needs to be broken down individually in regard to the interventions that you set. This needs to be highly personalized to each patient. So this first subcategory is sensory perception. As you see, each area that you identify, if they're completely limited, very limited, slightly limited, or no limitation, you have specific interventions for that patient. You'll also notice that a skin assessment and inspection every shift is for every subcategory except no limitation. You need to elevate their heels and use protectors. Consider specialty mattress. Use pillows between their knees and bony prominences. The second subcategory is moisture. Again, you'll see different interventions for each area. Constantly moist, of course, has the most interventions. Moist has most of the same interventions. Some ideas for a patient who's constantly moist is to moisturize dry, unbroken skin, avoid hot water, use mild soap and soft cloth, check incontinence pads frequently. Try not to use diapers, but if you do, check those often as well. Apply a condom catheter if appropriate, and consider bowel training if you're having a lot of issues with bowel incontinence. Activity. These are based on if a patient is bed fast, chair fast, walks occasionally, or walks frequently. For a patient who's bed fast, you need to be positioning them prone or elevate their head of bed no more than 30 degrees. Position with pillows to elevate pressure points. Elevate their heels. Consider a physical therapy consult if appropriate. Make sure to be turning them and repositioning them every 1 to 2 hours, and post that turning schedule for all staff to be on the same page. Teach the patient to do small shifts of body weight, and if they can't, help them do small shifts to be able to make sure to take that weight off of those areas often. Mobility. If a patient is completely immobile, you need to do a lot of the same things that you were doing for a patient who is bed fast or chair fast. So you need to be turning and repositioning them every 1 to 2 hours and posting that schedule again. Also do those frequent small shifts of body weight and consider a specialty bed if appropriate. Nutrition. This is very important in pressure ulcer development. A patient with poor nutrition needs to consider a nutrition consult, offer nutrition supplements and water. Encourage family to bring their favorite foods. Maybe they're not eating because they don't like the things we're offering them. Maybe if they had something that they really enjoy, they would eat a little bit more. Monitor their nutritional intake, and if they have not eaten or if they're NPO for a procedure over 24 hours, you make sure to discuss that plan with the physician. Friction and shear. So if this is a problem for the patient, you need to have a minimum of 2 people and a draw sheet to pull them up in bed. And for all patients, you need to keep bed linens clear, dry, and wrinkle-free. The next few slides go through pressure ulcer staging. It can sometimes be hard to remember or even be able to identify which stage a pressure ulcer is. These 2 pictures that you see are of healthy, normal skin. The right is of a darkly pigmented skin, and the left is lightly pigmented. As we briefly discussed before, sores can sometimes be more difficult to notice in darkly pigmented skin. Keep this in mind when completing your comprehensive skin assessment. So a stage 1 pressure ulcer is identified as non-blanchable erythema of intact skin. Remember to check if skin is blanchable or non-blanchable if it is warm or red. If it is non-blanchable, watch this closely and identify appropriate interventions. If the skin is purple or maroon, this would not be identified as a stage 1 pressure ulcer, but more likely a deep tissue pressure injury. Here is an example of blanchable versus non-blanchable. You'll see when it's blanchable, you'll see that white spot come up in the middle. When it's non-blanchable, you will not see that. Here are some examples of a stage 1 pressure injury. You will notice the skin is intact in all of these pictures. A stage 2 pressure injury is defined as partial thickness skin loss with exposed dermis. You will see a wound bed with a stage 2 pressure injury. However, you will not see fat, granulation tissue, slough, or eschar. Here is an example of a stage 2 pressure ulcer. The skin is no longer intact, however, you do not see any slough or eschar. A stage 3 pressure injury is defined as full thickness skin loss. In a stage 3 pressure injury, you may see fat, granulation tissue, slough, or eschar. Undermining and tunneling may also be present. However, with a stage 3 pressure injury, you will not see muscle, tendon, ligament, cartilage, or bone. Also, keep in mind that if slough or eschar is causing you to not be able to examine the full depth of the wound, this would then be considered an unstageable pressure injury. Here are some examples of a stage 3 pressure injury. Notice the picture on the right may have some undermining on the top right corner of the wound. A stage 4 pressure injury is defined as full thickness skin and tissue loss. In this pressure injury, you will often see undermining and tunneling. Fascia, muscle, tendon, ligament, cartilage, or bone area are often exposed. Again, if the slough or eschar are blocking you from seeing the full extent of the wound, remember it is determined as unstageable. Here is an example of a stage 4 pressure ulcer. We have talked a little bit about unstageable pressure injuries already. Keep in mind that the slough or eschar may not always be appropriate to be removed. So for example, stable eschar on the heel or ischemic limb should not be softened or removed. And here are some examples of an unstageable pressure ulcer. You'll see that it blocks you from viewing the full depth of the wound. And that is all I have today. I want to thank you for listening to this webinar on pressure ulcer prevention. Keep in mind that it is important on all patients to do a comprehensive skin assessment, a risk assessment, and to tailor those interventions to each patient individually. Also keep in mind how important it is to communicate the plan of care with everyone involved with the patient, including the patient and the family. Skin pressure ulcer prevention is such an important piece of giving high quality care. Thank you.